good morning or good afternoon if you're in Europe or so. Welcome to our cardiovascular grand rounds at Houston Methodist. I'm Dr. William Zogby, Chair of Cardiology here. And we have a treat for you today in our cardiovascular grand rounds. A very interesting topic by an individual who has made so many contributions to the field of imaging and health, Dr. Roderic Pettigrew. This is really an amazing contribution and a treat for us because Dr. Pettigrew serves as a Chief Executive Officer of Engineering Health, or NHealth, and Executive Dean of Engineering and Medicine at Texas A&M, and it is in partnership with Houston Methodist. This is an amazing program because it is for engineers who are interested in medicine in general and in health. So therefore, they go to medical school at Texas A&M in collaboration with Houston Methodist and become MDs with an engineering background, which is really amazing and a first really in the country. Dr. Pettigrew really does not need an introduction. He is an internationally recognized leader in biomedical imaging and bioengineering. He served for 15 years as the founding director for the National Institute of Biomedical Imaging and Engineering, NIBIB, at the National Institute of Health. Prior to his appointment at the NIH, he joined Emory University School of Medicine as professor of radiology and medicine and cardiology, and Georgia Institute of Technology as professor of bioengineering. He's very well known for pioneering work in four-dimensional imaging of the cardiovascular system using cardiovascular MRI. He has so many accolades and so many awards. He has been elected to membership of the National Academy of Medicine, the National Academy of Engineering, National Academy of Inventors, the American Academy of Arts and Sciences, and the National Academy of Sciences. His awards include gold medals from the Academy of Radiology, Research, and the Radiology Society of North America, the Arthur Buke Award from the National Academy of Engineering, and the Venar Bush Award from the National Sciences Board. He's graduate of Morehouse College as a Merrill Scholar, also from the MIT, as a Whitaker Fellow, PhD in Radiation Physics, and the Leonard Miller School of Medicine at the University of Miami, and completed residency training at UC San Diego. Really a pleasure to have Dr. Pettigrew, come to Texas, head this amazing institution, and collaborate with us on so many areas of cardiovascular medicine with his background in engineering. Dr. Pettigrew, a pleasure having you. And he will be talking to us about a very interesting topic: toward cardiovascular health and longevity, perspectives on microstructure, flow, and cellular mechanosensing.
Good morning, everyone. I'm going to turn off my mic while I clear my throat. Thank you, Bill. I really appreciate the opportunity to be here. Thank you for the kind introduction. Have a conversation with my cardiovascular colleagues at Methodist. And to get out from behind the administration desk. I want to begin by introducing my colleague who's in the room, Raja Muthu Pillai, who's in the back there. Raj and I go way back to the days when I and Alan Lumsden were both at Emory in the 1990s. Raja was and is an MR physicist par excellence. We worked together then, and I was so delighted when I got here that Raja was still here. I knew he left Emory to come to Houston to continue his work and his career. And he has over 30 years experience focused on cardiovascular imaging, specifically MR. And there isn't anybody in the world who understands MR physics and cardiovascular imaging with MR any greater than does Raja. He is one of the co-developers of a unique MR technique called MRE, or MR elastography, which has now become, I've learned, the #1 test for quantifying, diagnosing liver fibrosis totally non-invasively. So Raj and I are back together again. He's joined me in InMed, and you'll hear about some of the things that we hope to do. This talk is perhaps a little different than the typical Grand Rounds talk. It really is a talk about use-inspired basic and technical research, all focused on advancing the health and well-being of us all from a cardiovascular standpoint. And I want to start with this quote from Theodore von Karman. Theodore received the very first National Medal of Science. This was in 1962. He himself was an aerospace scientist. I think he coined the phrase jet propulsion. But he made this pretty interesting statement that is cited from time to time. Scientists study the world as it is. Engineers create the world that never has been. And I would say that at InMed and the work that we're doing and that we hope to do in collaboration with you, and obviously Deepan has arrived now, our goal is really to do both. We want to study the world as it is and use that improved understanding to create a world that never has been. When I first arrived here, Bill, I was at home and I got a copy of MIT Technology Review, and the cover was really exciting to me because it told me I wasn't old anymore. But the statement here, old age is over. So this was about 4 years ago or so. And the whole issue is on longevity. And you can imagine that this talks about advances in addressing and understanding the aging process. But as we look down the road and towards the future and actually achieving this goal, one of the emerging concepts is to develop digital twins. These are digital representations of all of the physiological and morphological data that we have about us and medical data on an individual by individual basis, with continuous monitoring to provide information that is informative and actionable. And in a broad scheme of things, I think that's where we're headed. But the kind of information that's available to us and that we'd like to have spans all biological scales. And indeed, I think the research that all of us are doing collectively addresses the issue of understanding the cardiovascular system in health and disease across all of these biological scales. An hour obviously isn't long enough to talk about all of these, and I'm not expert in all of these, but I'm going to draw on the work of a number of people from around the country and around the world and some of our own work to talk about microstructure, flow, the importance of flow, and mechanosensing as well. So I start with a clinical case, courtesy of Ben Chong and Raja, that illustrates the ability of MR to provide significant informative information, not only in a qualitative but also a quantitative sense. And this is something that you really appreciate here because of the excellent training that DPAN provides with its fellows. And I've set in on this and I've been witness to it. But here is a case that appears to be hypertrophic. On the second column, you see the delayed contrast and has images. There is this sort of patchy infiltrate enhancement in the lateral wall. There is inability to null the myocardium in any regional aspect of the myocardium, as would be typical with infarction. And in the polar maps, there are the quantitative displays of the relaxation time T1. In the top, that's the native T1, which is actually increased. At the bottom in the blue is a T1 as a consequence of giving gadolinium, the extravascular and extracellular contrast agent. And this dramatic drop in T1, it starts out being elevated, it goes way down. This big change is indicative of an increased extracellular volume. And indeed, the quantitation of this shows that the extracellular volume is about twice what is typically observed, what is typically normal. So we know that MR has this ability, and it's evolved over the years to provide these quantitative indices. And in addition to those kinds of quantitative measures, also the ability to quantify local biomechanics with tagging here and the tagging providing deformation as a consequence of placing non-invasive but nonetheless physical markers across the myocardium and seeing how those markers expand and change. And in addition to that, this emerging technique that uses phase encoding of the myocardium itself, the same technique that's used for velocity quantification in the blood, being applied to the myocardium so that on a pixel by pixel basis, we have this forward integration of the velocity and time in each of those pixels that gives you direction so that you can actually quantify strain with this technique called dense as well. And the combination of these two is an emerging powerful combination. So the ability to assess cardiac displacement, deformation, changes in the radial direction, the radial thickening is pretty obvious, but also circumferential strain, longitudinal strain are all within the grasp of this technology. Now, one of the emerging developments that really has started over the last half decade or so, maybe a little bit more, has been inspired by the success of diffusion tensor imaging in the brain, where this has been used in the brain to delineate the fiber tracts, the neuronal tracts, I should say, in the brain, and define the cerebral connectome. This is based on the observation that as water molecules travel along these fibers. They change and modulate the signal if that motion is done along an applied magnetic field gradient. And that change in signal induced by the motion of a water molecule along the magnetic field gradient can be observed, and because it is directional, this can be tracked and actually computed. This process called diffusion tensor imaging, where a tensor is just a fancy word that means you can observe a vector or a motion in multiple directions at the same time. And doing so, calculating the direction of water flow in 300 simultaneous directed calculations, extracting from that the positional changes over a period of time, and allowing one then to calculate these fiber pathways that you see there in fairly exquisite detail. This has been so successful that it has resulted in some fairly interesting and amazing findings in the brain, which I think has stimulated the application in the heart, which I'll mention in a bit. But just to tell you about one of the two interesting observations that you may or may not be aware of is that in the brain, where there are known functional areas within the brain, correlating those areas and looking at the fiber tracts and the density of the fiber tracts between known functional areas creates what is called this connectome. This can be plotted in a matrix, where you have the matrix that indicates the density of fibers that exist between two of the regions that are known to exist in the brain. And what is interesting and has emerged from the body of data that's being generated over the last several years is that this connectome that each of us has is unique. It is as unique as a fingerprint. And in fact, it's called a sort of a fingerprint connectome. It's so unique that it is predictive of this parameter called fluid intelligence, which is the capacity for on-the-go and on-the-spot reasoning. It doesn't refer to a fund of knowledge, but it refers to solving problems and making decisions. And the graph that you see here shows in a group of individuals what was a predicted fluid intelligence score based on an individual's connectome, correlated with the actual tested fluid intelligence score. This is kind of scary. But you can see not a perfect, but nonetheless an existing correlation there. In addition, researchers have indicated that the functional connectivity maps of this type are also correlated with emotional states and behavior. Neuroticism and extroversion were two that were studied. Again, quite interesting, this kind of fundamental information. So with this, I think researchers have taken on the daunting task of using diffusion tensor imaging in the myocardium. Now, I was at the NIH when this work began, and the inventor of diffusion tensor imaging, Peter Basser, who was a scientist in a couple of institutes at the NIH, one of them mine, we talked about applying this to the heart. And we talked about how challenging it would be because you're looking at small amounts of motion in a water molecule in a tissue that it itself is moving. So how in the heck could you really do that? And it's amazing. Hats off to the early investigators, their workout show, who have demonstrated that this does indeed appear to be feasible. So what I'm showing you now is the microarchitecture, the architecture of the myocardium. This is well known from pathologic and histologic studies that the fibers have this sort of, from epi to endo progression, have a helical orientation. It's a left-leaning diagonal helix at the epicardial part of the myocardium to more horizontal in the mid, and as you go to the endocardium, the orientation, the diagonal orientation, is more right-leaning, so this right helix, as shown by the arrows here in this graphic. This particular video shows the orientation, the major direction of this vector from epi to endo. So leftward leaning when it starts out mid, and then right leaning or right-handed in the endocardium. And the graphic up here is a simplified version showing this cross-hatching. This is the left-leaning structure at the epicardial layer, mid, and then endocardial layers. Now, several investigators have demonstrated now the ability to see this fiber orientation in the myocardium using diffusion tensor imaging. And one of the more interesting observations is now this new parameter that seems to correlate with pathologic conditions, and I'll mention a couple of those. So what one sees here now is across the thickness of the myocardium, shown in this animation, an array of sheetlets of myofibrils. And each of these sheetlets across the thickness of the myocardium, from epi to mid to endo, have this angular rotation over the course of the cardiac cycle. This angular rotation, in fact, explains why the thickening of the myocardium is substantially greater than the change in the thickness of the individual myofibrils. The radial shortening, the circumferential shortening is only about 15% or so. The growth in the diameter of the myofibril over systole of the cardiac cycle is only about 8%. But we know that the change in the thickness, systolic thickening, is substantially larger than that, several times larger than that. So how does that happen? Well, I think this explains how that happens. If you see this isolated sheetlet here and see this angle of rotation over the cardiac cycle, the leaning down or rotating down is responsible for the growth in the transmural thickness of the myocardium over systole. And in a couple of pathologic cases here in hypertrophic cardiomyopathy and at the top and a dilated cardiomyopathy, again, interesting findings. These graphics on the left, these are color-coded, and the color code here from going now from endo out to epi, from red to blue, represent the helical angle of the main fibers that I talked about from epi to endo. And you see that in hypertrophic cardiomyopathy and in this dilated cardiomyopathy, those angles are preserved. Right leaning in the endo, left leaning at the epi, more horizontal in the mid. During systole, I'll talk about this, but in this particular column, what this shows is actually this rotational angle of the sheetlets that make up the layers within the myocardium and how those sheetlets rotate. So this color code is a coding of the maximum angle that's obtained. The blue to red is the amount of the angle, and the greater the angle, the brighter this color. In hypertrophic cardiomyopathy, we see that this has a large angle. In the dilated cardiomyopathy, it doesn't. And here's a comparison between what happens at diastole and systole, but the movies, I think, are even more instructive. Here is the normal, we just talked about this, but in hypertrophic cardiomyopathy, there is a normal systolic thickening with this large rotation of the sheetlet. But it is incomplete relaxation during diastole. Notice here that it fails to return to the normal, more upright angle during diastole. Then in dilated cardiomyopathy, it's somewhat the reverse. During diastole, it returns to the normal, more upright position. During systole, it fails to rotate all the way down and has decreased mobility. And then also now, I'm reporting what's in the literature is that some recent studies of dilated cardiomyopathy in individuals who had a dilated cardiomyopathy were treated and recovered. When that happened, this failure to completely rotate all the way down improved, but it did not recover fully, even though clinically there was resolution of the dilated cardiomyopathy. There are challenges still with this. I think there's amazing progress with this particular technology given the fundamental challenge that I just talked about, that you're looking at small movements within something that's drastically moving. The way to overcome this is to have higher performance magnetic field gradients, because it is the gradient that imparts the coding of the motion and the change in the signal that's induced by the motion along the gradient. The stronger the gradient, the more sensitive you are to small motions. So for the last several years, as Bill and Deepan know quite well, I've been trying to get Siemens to build a scanner with these very, very high performance gradients, similar to the type that have been used in the brain, so that we could do our absolute best with cardiac imaging in delineating heart structure at the microstructure level, and also vascular structure and abnormalities, based on having this greater level of ability to spatially and temporally encode the MR signal with greater and greater resolution. So this resulted in the creation of this new scanner, which Siemens now calls the SIMA X. SIMA is Spanish for peak, standing for peak performance, top of the mountain. And I had proposed this as a beyond the state-of-the-art scanner, so I think the name is appropriate. That scanner has been delivered. It's now in InMed Tower, within walking distance from here. And Raja and I are busy trying to work through the preliminary software and sequences and really get it set up to do some interesting investigative studies. And when that happens, Deepan, I'm hoping that you and your stellar fellows will come over and help us to discover new things and solve problems that haven't been solved before. This graphic, which you may not be able to appreciate well, shows the gradient performance in terms of the gradient strength. That's the size, the change in the gradient in the magnetic field over distance. That's the vertical axis of gradient strength. And then how quickly that change is made, which is called the slew rate. The graph here, this red curve, is what the FDA had predicted was the combination of those two parameters that could be used in the whole body, here in red, in a way that would not stimulate peripheral nerves. But this system has been developed to have gradient performance that's substantially above that, is shown here. And thus far, it has a similar profile as does the Prisma or other 3T scanners. So I think the potential to use this to break new ground and make new discoveries is with us. Raj and I did submit an abstract and presented this. This is the first abstract of work done on a CEMA-X at this year's International Society of Magnetic Resonance in Medicine meeting, just held this past June. We applied this, however, to our lowest hanging fruit, which was diffusion imaging in the prostate. And diffusion imaging in the prostate has emerged as a very sensitive and excellent way of detecting prostate cancer early on. So we tested this, showed the ability to encode and measure diffusion with far greater sensitivity than had been reported previously, I would say by a factor of 2. Now, the potential for applying this in the heart is certainly there, and how might we use it? Well, one of the first ways in which this could be used is to delineate what actually happens with the advent of stem cell therapies in regenerating myocardial tissue. Determining on a microstructural level the impact of these cell therapies is something that this technique, I think, is particularly well suited for, and this is a promise on the horizon. I see here that Novo Nordisk has just started a heart cell therapy trial. The proposal here is to use DTI to assess what happens. Having talked with the science officer there, they really don't have a way yet of determining in any detail what really happens when you inject a family of these progenitor cells into the myocardium. This is also being studied now at Stanford in the Hector trial. This slide is from Joe Wu. And similarly to the trial that I just referenced is starting, they're injecting 3 different amounts in the family of cells: 50 million cells, 150 million cells, and 300 million cells being injected and then being assessed. The assessment is using conventional MR, as you can see here, and an array of laboratory tests. Being able to apply diffusion tensor imaging with the ability to assess whether or not these therapies actually produce the structure that is normal, and the function of that structure that is normal is on the horizon with this particular approach and with this scanner. So I think this is one of the things that we would like to pursue. One of the challenges that I mentioned is that you're trying to look at diffusion along a fiber, and the fiber itself is shortening and twisting and rotating. So you have these three motions, this displacement and deformation and shortening, that the diffusion is taking place in. But with the kinds of combined images that I just showed you, the potential that Kevin Moulin is showing here is to actually begin to look at these individually and tease them out. The previous slide, it was with all three movie. Here is just the deformation and shortening. And here, looking at fibril shortening only. And this color, it is color encoded. So this is one of the advantages that's on the horizon, and one that the SEMA is well positioned to further develop, and we certainly are interested in and hopeful that this will make the kinds of difference that we just talked about and be applicable to a range of applications, but certainly in evaluating the practical impact of these cell therapies as they emerge and determining exactly what's going on in the myocardium when you administer a cell therapy, maybe is a simple way to say it. This is one of our early images from the SEMA on a normal volunteer who's about 20 years old. And we've moved from the prostate to starting to look at vessels. We still haven't optimized the software. We haven't been able to use the full power of the scanner yet. We're progressing towards that. But this is a diffusion-weighted image of the vessel wall, and the ability to resolve the vessel wall in this individual with diffusion weighting and having that additional information in the wall of the vessel. It also has the advantage of removing adjacent flow that sometimes can confound thickness and measures of the vessel wall because of the slow flow and sludge along the wall. With this exquisite encoding gradients, we can eliminate this. The other goal that we have is even more challenging, and that is the improved resolution of being able to image the walls of coronary arteries themselves. This is an earlier publication when I was at the NIH, when we demonstrated the feasibility of 350 micron spatial resolution coronary imaging at 3T. That was done on a scanner that had gradients that were 5 times less strong than the gradient strength of the SEMA. So we are hopeful that the potential to move closer to 200, 250, I'd put as a goal 100 microns. You gotta have goals and visions. Whether or not we're able to achieve that, time will tell. But we're certainly hopeful that we can improve our ability to image the coronary artery wall in disease. In the last few minutes, I want to talk about some of the work that we have done here with our colleagues in John Cook's lab to investigate mechanosensing. And the backstory on this is shown here. We all know that fluid flow and shear along the vessel is a potent stimulant for gene expression, and that this plays a role in the development of atherosclerosis, and in the normal function and behavior of blood vessels, particularly vasodilatory changes in the blood vessel. High shear stress increases eNOS. It decreases these things that you don't want. So the way I think of it is high shear stress does the things that you'd like to have happen. It increases eNOS, it decreases oxidative stress, apoptosis, MMP activity, those inflammatory cytokines, and the residence times of those is reduced. When you have low and oscillatory flow, as is seen here in the carotid bulb, the residence time increases, and there's a greater chance of these inflammatory elements within the blood to take effect, and indeed you do see increased plaque in the regions of low and oscillatory flow. So we had this question based on this observation and the fact that the Cook lab has been very active in studying aging of the endothelial cells. The question was, how does cell aging impact critical shear stress sensing, since this shear stress is such an important driver of gene expression and vascular function, and particularly endothelial function. So here's our group. You know many of these, but joining us also was Jacques Ohayon, a long, multi-decade colleague from France who came here and did a sabbatical, is a biomechanician par excellence, editor of a series of Elsevier books on the biomechanics of various organs, including atherosclerotic lesions in vessels. So we spent some time exploring this, and we leveraged the work that John had done on progeria. You no doubt have seen this many times, has shown the lobulated appearance of the nucleus in the progeria cell and the ability to restore a more normal conformation with H-TERT, as shown there. So we sought out to investigate the extent to which cell signaling by way of shear stress is imparted in these cells that have this abnormal geometry and this abnormal conformation. Does that inhibit the extent to which flow is able to do the good things that it does, is a question that we were asking. And we just published our results. As you can see, this is a very recent publication, just a couple months ago, in the Cell Press Journal shown here, where the finding is the title, Disrupted Stiffness Ratio Alters Nuclear Mechanosensing. The graphic is shown here of what we were studying. Here is a cell. The flow and the shear stress is imparted across the cell, the apex of the cell, and the extent to which that signaling is communicated through the cell, through the cytoplasm to the nucleus, is what we sought to investigate and to understand, and how that changes in age cells versus normal cells were what we sought to understand. We took the progeria cells and looking at their altered geometry, hypothesizing that there may be disrupted mechanosensing and that these two are related, and had as this working hypothesis that the disease-induced biomechanical changes would indeed impact the shear stress transfer from the surface of the cell through the cell into the nucleus, and consequently gene expression. So this was performed using measurements on live cells, and there were 4 types of cells that I'll mention in just a moment, but here's a basic technique. Use atomic force microscopy to, to measure the stiffness of the nucleus and the cytoplasm of the cell. We then use computational biomechanics to study the shear transfer based on finite element model analysis, and use SIM, structured illuminating microscopy, to image these cells in topographic cross sections, and from that calculate the geometry, measure and then calculate and model the geometry, I should say, which then was used with this finite element model analysis. That, having that geometry, having those measurements of the stiffness of the cytoplasm and the nucleus, then allowed us to develop this 3-dimensional model over which we could map the stress across the entire cell and see what changes would occur with shear stress as shear stress is imparted on the surface of the cell. One of the beautiful things about models in general, once you get a model that actually works, is that it can be quite explanatory and explain things and interrelationships between parameters that are really difficult to get at just by experimentation alone, as well as predictive. But here are the 4 cell types that we studied. We studied the young human umbilical vein endothelial cells, those that were aged replicatively, IPS cells that were controlled, and then these progeria endothelial cells produced using IPS. And studied each of these and made the kinds of measurements that I just talked about with each of these. And what we learned in summary was a little different than what one might expect. You might think that in these aged cells, because they have such an abnormal morphology, that if there's a change in cytoplasmic stiffness or a change in the nucleus stiffness, that alone would result in a disruption in the communication of the shear stress forces across the cell. What we learned was that's not quite right. It's not the absolute stiffness of the cytoplasm or the nucleus. It's the relationship between the two. So the ratio of the two. So the stiffness ratio controls the shear stress transfer to the nucleus is what we learned. This is a graphic that I won't belabor, but just to say that this shows this because on the horizontal axis was an increase in the absolute stiffness of both of them, and when the absolute stiffness of both of them changes, the transmitted stiffness did not change, it was a flat line. But when the ratio between them changed, you can see this is a growth in transmitted shear transfer to the nucleus as the stiffness ratio changes between the nucleus and the cytoplasm. When the nucleus is not as stiff as the cytoplasm, there's a decrease in communication. When they're equal, this is maximal communication. When the nucleus is stiffer, that actually amplifies the communication. So the take-home messages here is that I think this parameter is a new parameter that we've discovered that needs to be considered when you're looking at diseases and therapies for those diseases in an effort to normalize gene and gene expression. If you have a therapeutic approach that modulates the stiffness of the cytoplasm, and only the cytoplasm, without a concomitant change in the nucleus itself, this will not be as effective as having them both change. Or, to put it another way, I think the relationship between these two is a critical determinant of the effectiveness of biomechanical sensing from blood flow into the endothelial cells, and how this ratio is modulated by therapies in the future, whether they be derived from mRNA, for example, or a general chemical. Either of those, it is important that one appreciates and investigates and looks at this parameter in order to determine how effective it will or will not be. The final thing I want to mention here in my last few minutes is that we are also focused on prevention and well-being and developing new technologies to accelerate the preventative aspects of cardiovascular medicine. This concept of actionable information from continuous data, the advent of wearables that we all now have, this Apple Watch that I'm carrying, this Oura Ring that I have on, as an example, we all have, and there are others that are growing. Here is a researcher at Purdue who developed a spectral analysis technology using a cell phone that's able to determine basically the level of hemoglobin that you have by taking a picture of your eyelid. This spectral super resolution spectroscopy technology that he's developing here, he's demonstrated can not only determine what your hemoglobin level is, but also diagnose sickle cell disease, as an example. He just won the top award from my old institute. This happened after I left, by the way, for that particular development. Now, while I was there, and I'm showing this because this is actually 10 years ago, we had focused on the challenge of passive blood pressure monitoring. This audience certainly understands the importance of quantifying blood pressure. So it had this idea of being able to walk through a doorway and it would sense your blood pressure, and it would send that information to your cell phone. Your cell phone would collect it all throughout the day, then summarize that, communicate that to you in a mirror. You stand in the mirror and it would tell you what your average blood pressure was. And then all of the individual readings that were captured would be shared with the physician. So this graphic that I'm showing you here, I actually had done 12 years ago now, and it led to an initiative. But what I'm rather inspired by and amazed is that we're beginning to see, just in the last couple of years, the emergence of smart mirrors that will communicate to you some of the indices that are being collected by these wearable devices. And here, there is an example there. But this concept led to an effort in partnership with India to stimulate the community to develop cuffless blood pressure monitoring systems. The importance of blood pressure is summarized here. This audience certainly gets it. Just a small change in systolic pressure, 10% change and 10 millimeter change in systolic pressure. There's a 20% drop in the incidence of acute cardiac events, stroke and death. You certainly get, but here is the announcement of initiative jointly between NIBIB and India in 2013, so 20 years ago, And the effort there was to develop devices that do not require cuffs. So one of our early investigators in that is now a colleague, Ruzbe Jafari, who is currently at Texas A&M, soon to be moving to MIT, has developed this bioimpedance wristwatch, which he calls a Bio-Z Beetle. It uses bioimpedance to get an arterial waveform from the wrist, and from that, decipher blood pressure. And here's the correlation between systolic and diastolic blood pressures obtained with this watch and with cuff measurements. As you can see, fairly strong correlation. This work is continued with Ruzbe, and now developing a tattoo that's bioimpedance that senses this waveform and has potential to extract blood pressure from that. And our latest development is an Aura ring-like device that also uses bioimpedance. Now, a word about bioimpedance is that this is preferable to the sensor in this Aura ring, which is optical, because of the diminution and transmission of the optical wave through tissue, particularly in people who have melanin or people who have a high BMI. So bioimpedance doesn't suffer from that. Consequently, we were successful in capturing an NIH grant just this year. The title, as you can see here, is a smart ring for cuffless blood pressure measurement focused on health disparities in people of color. And we're just starting that process now. But additional studies have recently been reported as we continue to develop and refine the algorithms that are used with artificial intelligence to go from this waveform to pressure. Pressure itself is very difficult to measure. I think waveforms are easier, pressure is tough. This I'll skip over, but simply to say that one of the additional things that we're doing is tackling the impediment of not being able to feel and do a physical exam remotely. In this age of telehealth, you know, you can listen, you can see, but you can't feel. So we just got an NSF grant that addresses this problem. Imagine having two sets of gloves, one that the nurse wears in a remote site, another set the physician has in her office. And you feel what the nurse feels, and you can see where the nurse has his hand. So that's in development now. I do want to end with these two slides. This particular slide is just inspirational to me. This, I'm calling the vision before television. This was telehealth, and having this vision of telehealth, even before there was television, is awfully inspiring for those of us who are trying to do things that haven't been done before. Look at the date on this cover of Radio News, 1924. This was before TVs were even invented. And look what's on the cover. A TV with the doctor communicating with the patient with the stethoscope that he's listening to, and he's hearing what the doctor's hearing what is happening here with this kid remotely, and the recording and the data's there, and they have this visual communication even before there was television with the camera above the television is there. It's amazing. I mean, this is just what we're doing. And this was even before they invented it. So this concept of having a digital twin that integrates all the biological data that we have across all of the scales, from microstructure to cell and molecular level, this information on mechanosensing, to this kind of wearable information that we have, in addition to the genetic data that we have and the data that's in typical medical records. having this updated continuously by way of having these wearable devices that give you updated data would allow us to create a twin of our cells from an informational standpoint, and from that actually using AI to ferret out indicators of changes that indicate a disease or an emerging process at a time where an intervention could be optimally impactful. So this kind of actionable information is what we're after. This is one of my favorite quotes. Is actually I've paraphrased. This is a combination of a quote that I've changed to communicate what I'd like to say. If we think today as we thought yesterday, we rob ourselves of tomorrow. Thank you so much.
Thank you so much, really, for an inspiring and futuristic really presentation today, and really amazing. I have one question before we open it. The super magnet, the SEMA X magnet.
While are you asking that, I'm going to drink some water.
Sure. Are we talking about improvement in spatial resolution predominantly? And what would happen to the temporal resolution? Can we use it for diastology, etc.?
Excellent question. Yes and yes.
Yes and yes.
We are talking about improvements in spatial resolution and in temporal resolution, and our ability to sense small changes, particularly small movements. So movements are detected on MR quantitatively by virtue of an induced change in one feature of the NMR signal, which is called the phase, which is the position of the spins. And that change correlates with velocity. It also correlates with the strength of the gradients. The stronger the gradients, the bigger the change for a small amount of movement. So our ability to look at things that don't move very much, but do move physiologically, and in some ways could indicate pathology, would be dramatically increased. The gradient strength also encodes distance. So the stronger the gradients, the more you can resolve a smaller distance. And that should improve the spatial resolution as well. But is not a piece of cake, I can tell you. There's always trade-offs, as Raja knows, as Deepan knows. As we go to smaller and smaller voxel sizes, the amount of signal contained within that voxel decreases, so that the signal to noise starts to go down. So while in theory we can get these tiny voxels, at some point we're going to be signal to noise limited. That can be improved with some physics modifications, such as creating echoes at short times, and the small gradients and high gradient speeds allow us to do that. And that's why it will take us a while to really get the sequences tuned up so that we can optimize the theoretical potential of the scanner and realize, I could say, the optimized potential of the scanner.
Dr. Shaw?
Yeah, so Rod, thank you very much. I mean, that was really an outstanding kind of overview, and I congratulate you in taking on this project. You know, one of the things I always tell the fellows is one of the beauties of MRI is that you can trade things off however you want. You can trade for higher spatial resolution, higher temporal resolution, shorter breath hold times. But in the end, everything is a trade-off, one or the other. This now is a fundamental shift in that curve, or the potential for that, which I think is really outstanding. So two questions for you. One is, of all the potential applications, where do you see kind of the killer application potentially being for a technological advancement like this? And then secondly, the question I'm going to ask you, as your career has gone beyond just MR imaging and much more from a global perspective, maybe give a word of advice to the fellows and the residents that we have in the room here as to how do you pick what to go after from a early career standpoint.
Okay, some great questions, Deepan. This initial question about trade-offs, so true, and trade-offs will never stop. We got this thing called the Heisenberg uncertainty principle. Anything you try to measure, you're going to change it, and so your measurements are going to be imperfect. And there are trade-offs here as well. In terms of the killer app, I have an application for which I am hopeful. And then there are applications that I think are maybe a bit more realistic. Raj is laughing at this. The realistic applications are to apply to things that I just said that involve small amounts of motion that are important, and the diffusion tractography and the microstructure of the myocardium, getting a better understanding of microstructure, how that changes. Why, for example, in dilated cardiomyopathies, even though there appears to be a functional recovery by conventional measures, do we still see this failure of the myocardial sheets to completely revert back to normal? It's sort of a question. There must be something fundamentally going on there. The application to regenerative therapies, this could be a really big deal, I think, if we really realize cell therapies that are able to regenerate myocardial tissue, and that after you have a heart attack, it's not over. That would be marvelous if we could regenerate the tissue that's now scarred. Having a tool that guides the development, tells you what your therapy is doing, whether it's working, not working, et cetera, I think would be a tremendous application. There are applications in other areas that are not cardiovascular that are obvious, but I'll restrict my comments to cardiovascular based. The hope that I have, and this is where Raj is going to start laughing, my hope is that we can just eliminate heart attacks. No more heart attacks. A world with no more heart attacks, Dr. Zogby, and no more strokes. If we could eliminate strokes and heart attacks, that would be a fantastic goal. We got so many tools now to look at the cardiovascular system, including the coronaries to some degree, but we're still having a whole lot of heart attacks. So one of the driving motivations was, let's push MR as far as physics will allow us to push it, and determine if that will help us to end heart attacks by detecting atherosclerotic lesions early on enough that you really can prevent someone from having an acute event. That's sort of the view and the goal. And every time I see that 1924 picture, I think about that. I mean, who would have thought this would be real, but it happened. It's amazing. Your other question to the residents? Well, one of the standard answers that you typically get, which has a real foundation and a basis for it, is, follow your passion. Follow what you're good at. At the end of the day, you have to have satisfaction in your job and what you're doing. So I would follow what your passion. But I do like to look for opportunities to make a difference. And that's what I tell our in-med students. When we graduated the first class, I challenged them all and told them that they were actually educated and prepared to go forward and make a difference. Be a difference maker. If you're a difference maker, from my perspective, you have job satisfaction. You got to make a contribution, make a difference. And making a difference can be in a lot of ways. Whether you're the communal physician or the community physician, or you're president of the American College of Cardiology, or you are a leader of a stellar imaging department and research group, you can make a difference. And I think that's really what it's about. We can't all do the same thing, we just do it in different areas, but move the needle.
That's beautiful. Beautifully said, really. I think that's a wonderful advice for most, not only the young individuals, but your career is ahead. And thank you for sharing not only the science, but also your inspirations, Rod.
Thank
really
you.
Beautiful. Thank you.
Boy, did I have a dry voice, dry throat.
Thank you so much.